Good afternoon, everyone. I'm from India. I'm working as an associate professor in Department of Speech and Hearing. So here I'll be highlighting on single case report. So now we are discussing with respect to different types of sensitivity. So these are the different types of sensitivity and specifically hyperacusis. So this is one definition among so many definitions I have put, that is intolerance of certain everyday sound. So specifically in hyperacusis, the uncomfortable level of the individual will be drastically reduced and the overall dynamic range of the individual is reduced. And with respect to the prevalence, specifically with respect to children, it was found to be 3.2%, and specifically children who visits audiology department, outpatient, it is reported to be 17%. And pathophysiology for hyperacusis may be peripheral and central. And with respect to site of lesion, we can classify them as cochlear hyperacusis and the vestibular hyperacusis. And with respect to the symptoms, how within the hyperacusis, the different degree of hyperacusis can be classified with respect to again the dynamic range of the individual and with respect to the loudness discomfort level of the individual. And these are the assessment procedure what we follow in our department. And this is one slide regarding the treatment and management options for hyperacusis individual. So moving directly on to the case report, a 3-year-old boy came to the Department of Pediatric with a complaint of unable to talk in sentence level and unable to walk properly and recurrent upper respiratory tract infection. So they have referred to Department of ENT, where basically they say that it's a complaint of unable to bear the bell ringing sounds and the firecracker, and they also reported speech difficulty and delayed development. So from there we got a referral, that is to the Department of Speech and Hearing. We have done a detailed speech and language evaluation according to receptive expressive scale. The reception and the expression of the child is delayed, and as observed and reported, there was no behavioral deviation with the child. And detailed hearing evaluation was carried out. So brief history again says no complaint of reduced hearing, startled response and crying for soft and loud sound reported, and otologic history says recurrent upper respiratory tract infection. Even though the child is 3-year-old boy, we couldn't do conditional play audiometry, so that's why we carried out behavioral observation audiometry. The stimulus used the FM tone and the speech sound, and response what we observed is head turn responses, smiling responses, searching for a source. Those kind of responses was obtained for FM also, and the 500 Hz, 1 kHz, 2 kHz tone at around 20 to 25 dB HL. And intolerance to sounds as loud as 60 dB, and the child response was closing the ear, and he was indicating that he wants to go out of our the clinical lab itself. So that was a response what we obtained. And autoacoustic emissions was carried out, and it was observed bilateral TEOE absent, and ABR the fifth peak was present with 40 dB NHL with good replicability and morphology. Okay, so it's an indicative of normal hearing sensitivity. But we couldn't do impedance audiometry and the tympanometry, and with that we have given an impression of hearing sensitivity within normal limit with hyperacusis. So recommendation, the other team evaluation was recommended. And moving on to the discussion. So here at this point we thought that we need to differentiate this case with respect to phonophobia and hyperacusis. Okay, and as we have done a detailed analysis with respect to the symptoms, like if you see the feature wise, so if you see the hearing threshold, it was within the normal limit what hyperacusis says, and uncomfortable level was reduced, and we have got 60 dB. Dynamic range also reduced, and we have obtained around 35 dB, and loudness discomfort level was around 60 dB. But autoacoustic emission was present, supposed to be present in hyperacusis, but it was absent. Maybe the child had upper respiratory tract infection, maybe because of that we thought it is absent. So The child was consistently responding for speech and non-speech sound at 20 to 25 dBHL, but the child was not able to tolerate the sound after 60 dBHL. And the dynamic range was 35 dB, so we thought it is a severe hyperacusis case. So possible mechanism in this case, maybe it is more towards the immature but normally developing auditory system. So to conclude, hyperacusis is a perceptual intolerance to sound. It can occur both in children and adult without any structural damage. Detailed audiological evaluation is very important, and choosing the right intervention also is very important. These are few references what I have followed. Thank you.
This is the best place to ask this question because this is something that they, as a group of scientists who have come together to talk about sound sensitivity disorders, this is the best place to differentiate between recruitment and hyperacusis.
Yes.
So I'd like you to explain to us, do you think hyperacusis and recruitment are the same, or can they coexist, and how do you differentiate between them?
According to what I have read and what I have seen the patients, I say hyperacusis and recruitment is completely different. And generally, recruitment you can see more with respect to sensory neural individual, specifically to talk sensory loss, okay, where they say that uncomfortably level till one point they hear normal, and after that suddenly abrupt uncomfortable, that is more with respect to recruitment. Where in hyperacusis, what I feel is hyperacusis can be there in normal hearing individual also, whereas recruitment usually you can, or most of the time you can see only in individual with sensory loss.
You suggested that the audiometric thresholds were normal, detection thresholds were normal, but you couldn't measure autoacoustic emissions, and that seems strange because normally if the emissions are absent you would expect elevated thresholds. What do you think is going on?
Sir, because autoacoustic emission with respect to this case, we are trying to say that the child had upper respiratory tract infection, and OE is one of the sensitive tool, and if upper respiratory tract infection or slight cold also if it is there, there is a high chance that OE can be absent. So why I am saying normal hearing is because of AVR threshold. The auditory brainstem response was absolutely normal. For 40 dB NHL, there was a good fifth peak and good morphology was there. So with that, we are saying that the child is having normal hearing. And even the behavioral observation, the child was consistently responding around 15 to 20 consistent responses. That's why we say it is normal hearing.
Yeah, I still find it puzzling. I think there might have been something wrong with the measurement of the OAEs, because if thresholds are normal and ABRs are normal, then the OAEs should be normal too.
Sure, but
station 2 dysfunction.
yes.
Maybe yes.
The child possibly had some sort of middle ear fusion because they couldn't do tympanometry. So
yeah, but that would affect the ABRs as well. If you've got a conductive hearing loss,
correct.
it
But
should
it would have been
like sir, for example, if the child is having little bit wax also, there is a high chance that the OE can be absent, because OE is one of the sensitive tool for and we have observed correct, exactly. So within our knowledge, we have tried framing this case as hyperacusis, and unfortunately the child was did not come for follow-up. So that was one thing. We tried, we have planned for the management with a psychological team also, psychologist also, but the child did not come for the follow-up.
So to be announced next year, you will tell us what's going on. Maybe you can see the child again.
Yes,
next year let us know. And make sure to do the transit
OE again we can do and we can confirm it.
Question over there, please.
Hi, and so I just have a question about the child's expected language. So you said that it was delayed.
Yes.
I'm just wondering whether you could just comment on that a little bit more. So in other terms of development, the child was normal and there was no signs of any other kind of learning difficulties or any spectrum disorders that you...
The child was actually 3-year-old, and the child language was around 1 year age, and the child also had global developmental delay, and lack of stimulation also was there. Okay, and that may be the possible reason why the child is having delayed language. So that is maybe the thing.
So I guess to follow up that. So
Yes, follow up will answer many questions. Even I have many questions with respect to that. So we are waiting. So if the child comes, we'll get answer for all this.
Yeah, and I guess, well, I'm not super informed on this because I don't work in paediatrics, but from some experience I've had, it is common for children who are developing in a slightly delayed way to exhibit signs of hyperacusis or some form of overwhelming responses to kind of their general environment. So do you think that it was that the child definitely had hyperacusis, or perhaps this was, if they had a global developmental delay, was it perhaps that they just weren't processing everything in exactly the way we'd expect?
Yeah, because see now why we are saying it as hyperacusis is the response what the child is showing was very consistent for the loud sound. Okay, in fact, when we were testing the child during the audiological evaluation, the moment we presented around 60 dB, he was indicating that he wants to go out of the lab, and with that symptoms, okay, we are the classifying the child into the category of hyperacusis, both the behavioral observation and all those things. So with that, we thought it is mostly the hyperacusis case.
Very good. If you don't mind, I'm going to go back to the question that I opened on the floor. I do believe that people who have recruitment, they may have hyperacusis also. It's a condition that, if you're considering hyperacusis as a distress to relatively loud sounds, it is possible for a person to have hearing loss and recruitment and show a negative emotional reaction to the sound, which is hyperacusis, very likely. Do people agree with this? How many people say yes?
And phonophobia.
And
Because if it
phonophobia.
doesn't feel good, they're then going to get
Yes.
frightened about it.
So it is possible to have hearing loss and show sound sensitivity and problems such as hyperacusis or phonophobia.
Yeah, I mean, my own personal experience is a bit like what you say. I wouldn't say I have extreme hyperacusis, but I have quite very strong loudness recruitment, and I'm less tolerant of intense sounds than I was before I had the loudness recruitment. So, I played in a rock band and I was quite happy listening to 110 dB. Now, anything over 85 or 90 and I don't like it. And it may be linked to the strong loudness recruitment that I have.
But do you show an emotional reaction to it?
Yeah, I find it aversive, yeah.
So,
I try to avoid
that
it.
can be some sort of a mild case of hyperacusis that our expert has. Excellent. Thank you very much.
Yes, thank you.